I'd like to thank everyone for participating in today's HCC coding training. Today, we'll be covering 2021 ICD-10 coding updates as they are defined in the ICD-10 book, identifying the changes which occurred throughout the chapters, how to identify those changes in the chapters of ICD-10 book, and we'll also cover coding guidelines related to hypertension, CKD, diabetes, and some other clinical conditions that changed throughout the ICD-10 book between last year and today. We'll also look at coding criteria and guidelines related to COVID-19. So we'll give you proper documentation guideline criteria related to COVID and the manifestations and how you would document that information within your claim. So I'd first like to start with giving you updates on the sweep dates. So as many of you know, we have just completed the March 2021 sweep. Our next focus would be looking towards completion and receiving data for 2019 dates of service. So CMS has extended the time allotted for us to submit your ICD-10s from 2019 service dates. We have through August to get your encounter data, your supplemental data, any additional gaps that we should have related to your chronic diseases and diagnoses for 2019 service dates. That window is still open, so we are still accepting data for 2019 service dates. We are also working towards 2020 ICD-10. The sweep will be in September, so we want to continue reviewing our care gap reports and data reports to make sure that all of your data for both 19 and 20 are in our system, preferably no later than the end of July, to ensure that we have opportunities to collect information, validate your data, and resubmit or communicate with your offices if there's any changes or any updates or clarification necessary to properly submit the data. So those are the timelines. We also have a timeline worksheet or calendar, if you will, that goes out through our provider services team. So we will redistribute the information related to service dates and which dates are captured throughout the CMS sweep dates. So we just want to give you an update on when we're expecting or when you should submit your data for 2019 and 2020 dates of service. So jumping into the presentation. Here. So there's many changes that occurred between 2020 and 2021. But I thought we'd just take a step back, and as you're documenting and coding, kind of identifying how we review that information within our ICD-10 books and how we obtain updates regarding the codes that we're currently using and documenting. This is important because we want to make sure that if you're using EHR systems or paper charts and you're going to ICD-10 books, that we are updating our code files to make sure that any deleted codes or codes that were added as additions, those additional codes would count towards risk adjustment in some cases. And so those codes are going to be key to capturing the RAF, and which is risk adjustment factor, and also capturing additional chronic disease and conditions that were identified. So here in the summary, based on the ICD-10 CM release, you'll see there were 490 additional codes added, 58 deletions, and there's 47 revisions to certain chapters. So here, the impact, of course, and we've covered this information before, that you have to have the clinical documentation for coding. The rules are, if it didn't occur, or if it isn't documented, it didn't happen. We want to make sure that we're complete, accurate, that we're going to lead to the maximum reimbursement by using accuracy of coding and documentation. And we're also aware of which codes will risk adjust based on the documentation that you're sending over. So last year, we know there's a lot of telehealth services, and you may have doctors who have communicated with members via telephone. And so documentation is key there. So even if you were completing certain communications with doctors, CMS released a file of a list of telehealth service codes so that we could properly document all the different types of communications that occurred for the patient, so related to the patient's care. So here you'll just see that that's just a reminder that we want to ensure that we're documenting properly and accurately. So the ICD-10 official coding guidelines. So most of you, if you're using an ICD-10 book, and I know some of you have moved to EHR and electronic versions, but there is an official ICD-10 guideline for coding and reporting. Within that guidelines, there's narratives that are identified in bold, and we have some italicized underlined diagnoses and conditions in the header that are in bold. So this is just kind of a description to help you identify those particular changes which were made in the official coding guideline and reporting criteria. What we did is, based on this information, we pulled certain guidelines and clinical criteria that we wanted to cover through those changes. So there's documentation by clinicians or other patient providers. So, you know, as we move through, you know, members being at home and there's other social factors and determinants with people that are experiencing homelessness and some other patient self-reported conditions, there are lists of codes that will assist us with documenting self-reported conditions. You may have heard the term social determinants of health. Within the CMS guidelines and within the ICD-10 book, social determinants can be reported through your encounter data. So here's an example of Z59.0, where a patient has self-reported homelessness. There's many other social determinant codes that are available under the guideline in this particular section. So I just wanted to, you know, inform you that if you are aware of any patient social determinants, you can document that information within your charts and your progress notes. Another change that we wanted to highlight here in Chapter 4 is for diabetes and the use of insulin, hypoglycemics, and injectable non-insulin drugs. On the second chart behind this, I'll show you a description of those particular drugs. But if the patient is treated with both insulin and injectable non-insulin anti-diabetic drugs, we want to assign a code Z79.4 for long-term current use of insulin and Z79.899 for other long-term current drug therapies. So if a patient is treated with both oral hypoglycemic drugs and an injectable non-insulin anti-diabetic drug, we want to assign Z7984 for long-term use. So the reason we want to code these additional statuses of the patient's insulin use is so we get an additive factor on our risk adjustment and coding in addition to our diabetes. So these are just examples of, in addition to your diabetic codes that you're using, your E-codes, that you want to include this information if it's present in the patient's chart or medical records. So below, the next chart here, this is a description of the non-insulin anti-diabetic drugs that we were talking about in the prior slide, and just kind of gives you an explanation of what those drugs are used for. So it's a drug that helps to keep the food in the stomach longer by delaying emptying and increasing the amount of insulin. And so these are particular drugs that you would look for when you're identifying this class of drugs that we're calling non-insulin anti-diabetic drugs. So here's your list of those drugs or therapies that you would look for when coding there. Chapter 9, this is the update for Chapter 9. So hypertension, we want to code the causal relationships between hypertension and heart involvement, and also between hypertension and kidney involvement. So in the alphabetical index, we talk about linking. So we want to link those conditions that are associated with other clinical conditions. So we should be coded as related unless the documentation clearly states that the conditions are unrelated. So for hypertension and other conditions that are not specifically linked with, associated with, or due to, then the provider documentation must link the conditions in order to code them as related. So within this Chapter 9, you know, there's full description on hypertension, the relationship, and how those services are coded. You want to make sure that we're properly linking all associated conditions with hypertension. So here is an example of hypertension with heart disease. So hypertension with heart disease conditions classified as I-50, 51.4, 51.47, et cetera, are all assigned to the code category I-11. So hypertension, heart disease, we want to use additional codes from the category I-50 to identify heart failure, in those patients that have heart failure. So that information, we should identify both code categories so that we're associating our hypertension with heart disease. And then here, the same heart conditions. So here are same range of ICD-10s, the I-50 category code with hypertension are coded separately if the provider has documented that the conditions are unrelated to hypertension. So these are two examples of how we would relate the hypertension code with another heart disease, ICD-10, or if the service or conditions are unrelated. Additionally, we have hypertension, heart, and chronic kidney disease. So you'll see that we identified the hypertension, heart, and chronic kidney disease as assigned in the category I-13 when there's hypertension and both heart and kidney involvement. So if heart failure is present, we want to assign an additional code from category I-50 to identify the type of heart failure. So we're looking at category I-13. We're then moving on to say, okay, there are additional failures or additional category or conditions that we should assign, and that's our I-50. For the chronic kidney disease, the appropriate code from category N18 CKD should be used as a secondary code with the code from category I-13 to identify the stage of CKD. So as you can see, as we go through the charts or as we go through our records, we have a primary condition of hypertension, and we're identifying additional chronic diseases associated with the hypertension, and we're continuing to add the ICD-10 codes that properly describe heart failure and those ICD-10s that properly describe the CKD and add those to the chart. So for patients with both acute renal failure and chronic kidney disease, the acute renal failure should also be coded. So we want to make sure that we're not leaving any conditions or diagnoses from the patient's chart or encounter when you're submitting, because this will all contribute to your risk adjustment factor and to the RAF scores and to the payments that we're receiving when we submit to CMS. So additionally, hypertension, chronic kidney disease, same structure. We want to assign from the category I-12 for our hypertensive chronic kidney disease for both hypertensive and conditions classifiable to category N18 or CKD. So more examples of adding an additional code or coding separately for our CKD category. So you can see here, we're appropriately coding from N18. It should be used as a secondary code with a category from I-12 to identify the stage of chronic kidney disease. So these are the sequences that we want to include when we're documenting and coding for chronic kidney disease. So the next slide, we're going to show our COVID-19 guidelines and how we should submit our billing for coding and documentation of COVID-19. So we're all familiar with the U07.1 for confirmed cases of COVID-19. We're also seeing additional categories related to fevers and related to other conditions that are associated, and we want to properly document that information when submitting. So U07.1 is the diagnosis for COVID-19. If the provider documents suspected, possible, probable, or inconclusive COVID-19, we do not assign U07.1. We want to assign a code explaining the reason for the encounter, so such as fever, contact or suspected exposure. Z20.89 should be the proper diagnosis if we're unconfirmed. If we have an unconfirmed diagnosis of COVID, we want to use the Z20.828. When COVID-19 meets the definition of the principal diagnosis code, U07.1 for COVID-19 should be the sequence first, followed by any manifestations or appropriate conditions. So you can use your U07.1 followed by, your fever diagnoses, or other respiratory diagnoses could also be listed. So we want to be sure that when we're submitting for COVID-19 diagnoses, that we are not submitting unconfirmed cases of COVID through your encounter data or submission. So here on this chart, we're showing acute respiratory illnesses due to COVID-19. So we talked about the U07.1 for COVID-19, and below there, you'll see that these are all the additional respiratory conditions that we're associating. So here's pneumonia, and you can see our COVID diagnoses with pneumonia, ICD-10 J1289 that's being added as a secondary diagnosis. We're also looking at, sorry.
I'm sorry.
Liz, are we able to mute the line?
I'm sorry, Fabian, can you please mute yourself?
Thank you. Okay, so we're also looking at U07.1 COVID-19 and its association with acute bronchitis. So here you'll see the J20 listed for acute bronchitis due to other specified organisms. And so through this chart, we see that we have our COVID-19 diagnoses of U07, and we're also adding additional manifestations. So we're also adding additional manifestations for respiratory infection, respiratory distress, and acute respiratory failure. So those additional manifestations are being added to our COVID-19 diagnosis code when you're submitting the condition. So next we have conditions that are non-respiratory manifestations of COVID-19. So U07.1 for COVID-19 and assigned codes for manifestations and additional conditions. So here you'll see that the Z codes, we show that there was exposure to COVID-19. It's suspected, so that should be our proper diagnosis codes for suspected or exposure to COVID-19. And screening for COVID-19. So during the COVID-19 pandemic, a screening code is not an appropriate diagnosis. So you should not use the COVID diagnosis for any screenings related to COVID-19. Below are additional ICD-10 codes that we could apply to our conditions or diagnoses where we have not confirmed COVID-19. So if there's a cough, shortness of breath, fever, exposure, below are the list. This is a list of those codes that you should submit through your encounters until you have a confirmed case of COVID-19. If it's asymptomatic or they test positive, of course, we want to document and use the U07.1 to document your COVID-19 diagnosis. Next, we have the personal history or the encounters for the antibody test code. So here you'll see that there's a Z86.19 for personal history of other infections and parasitic disease. So this would be your appropriate code. Follow-up after COVID-19 is resolved, you'll see there's additional encounter codes for resolved or personal history cases. These would be your ICD-10, Z09, and Z86.19. And Z01.84 here, encounter for antibody response examination. So the set of code sets that we're seeing here, as you can see, there are multiple ICD-10s to describe the stage or the condition of COVID-19. So just to go back, look at your medical records, look at your EMR to make sure that we're applying the correct status codes for COVID-19. So diagnosis, coding, and chapter updates. So here, and I won't go through each individual chapter, but we'll highlight on a few. You can see here that by chapter, these are some of the codes which were deleted, and there's additions. We're more concerned here on those that are added to. Some of the added codes will risk adjust. So if you have not updated your code guidelines or your coding in your EHR system, we want to be make sure that you have all those additions. So you can see here, diseases of the blood. A lot of these conditions under the 43 added conditions will risk adjust. So ensuring that you've updated ICD-10 criteria so that we pick up your additional diagnoses there. Continuing on, chapter 4, 5, and 6, we outlined the categories that are deleted or additions to those categories. In this middle section, when we talk about mental health, behavioral health disorders, we can see that there were quite a few codes added to alcohol abuse. And so these are the diagnoses codes, which are examples for alcohol abuse, withdrawal, uncomplicated. And as you know, this is always one that's probably underdiagnosed. So if we could, take a look at our records and make sure that we are properly using the correct 4th or 5th digit diagnoses codes related to alcohol abuse or behavioral health disorders. So this is chapter 5, where you'll find those particular changes. And then chapter 6, additional code deletions and new code categories that you should have for the diagnosis changes under chapter 6. Chapter 7, there's additional I categories and disease, so you can see the code range there. We had changes in chapter 7, no changes in chapter 8 of the book. So for tabular changes, so these are tabular changes that occur within the ICD-10 book. So we just kind of highlighted what we talked about earlier related to hypertensive heart disease. So those changes will definitely affect RAF4. So making sure that you have the correct digits following the decimals to identify specificity when you're coding and documenting. And these are just tabular changes in your ICD-10 book that describe those changes and how you would identify those changes in your ICD-10 book. Here. Next, chapter 10, 11, and 12, there were additional codes added to respiratory symptoms. So here are your code ranges for respiratory symptom diagnoses. Digestive system, 12 new codes added there, and no changes to chapter 12 in the ICD-10 book. So these code changes are going to be key to making sure you're picking up new codes. Here, there are additional or more codes. You can see that there were 57 codes added to chapter 13. So we want to ensure that we're picking up all of the added codes to make sure that those are coming in through your risk adjustment and RAF. Same thing with deletion. So you can see here, this was a big one because we see a lot of this in your diagnoses code. So we deleted the N18.3. It does not include the proper digits, so that code is now gone. And it's been added, so we added N18.30 for CKD stage 3. And if you remember last year, we are now able to report stage 3, 4, and 5 for risk adjustment, whereas before we were only able to report stage 4 and 5. So this is a big one. And through some of the other trainings, we talked about maybe identifying your members that you had previously diagnosed in stage 3, where it did not risk adjust, and reevaluating or reassessing, making sure that that documentation appears in your charts for 2020 and 2021 dates of service. So here's your proper code for CKD stage 3, and it will risk adjust when properly documented. More changes, and I won't go through each of these, so we'll provide you with this presentation. But just keeping the same status is just knowing that within those code files, within those ranges, there are many deletions. If you're submitting a deleted code for the reporting year, it will not count towards risk adjustment. And so the importance here is that you have all of your code files mapped and that you're submitting the updated code so that you're not receiving any rejects for invalid ICD-10s for the data service in which you're submitting. More codes, we'll look at additional codes here where you can see that there's just many changes and adds to the ICD-10 structure and many deletes that you want to remove from your ICD-10 code. So we'll provide you with that. Within chapter 22, there are special purpose codes. So we have, vaping disorder related codes, and of course the COVID-19 diagnoses code sets are all available. So all of these are changes to the ICD-10 code chapters. So next we'll move into risk adjustment and coding. So just to keep it in front, if we have any new individuals joining, risk adjustment, what it is, it's a statistical process that takes into account the underlying health condition or status from the enrollment insurance plan to help with their healthcare outcomes and healthcare costs. So the term RAF or risk adjustment factor, we use all of those terms to identify a score, and which CMS uses to calculate the risk factor for a member based on their chronic diseases or diagnoses. We also look at their gender, their age, their socioeconomic status, and insurance status, and that's how we determine a risk adjustment factor and payment for a member. And the goal is to reduce the CMS financial exposure by paying based on the risk of the healthcare required for the condition of the enrollment. So the sicker the patient, CMS will reimburse for care of that patient. And in order to do that, we have to ensure that all of the chronic diseases and conditions related to the member's care are documented in your EHR. And when we're doing that, we are looking at a risk adjustment model. So the risk adjustment model is a table that documents all of the ICD-10 codes that are within this model, and it applies an HCC category code or a hierarchy condition code that's based on what Medicare assigns. So these are the models that we generally follow as we're following the HCC hierarchy condition model. There are others. There's commercial model, there's DRG model, there's pharmacy model. So there's additional models, but our focus today would be on the HCC hierarchy model that's released from CMS. The Medicare model that we talk about, it makes up the ICD-10 codes, which are then grouped into diagnosis code groups or categories. Those diagnosis categories are then grouped into condition categories, which then make up what we call an HCC code. So you're familiar with the term an HCC code. And based on that HCC code, we have a risk adjustment factor that is used to help with calculating the member's risk score. So when we talk about risk adjustment factors and RAF, we are using the clinical complexity of the patient to predict the burden of illness. So do we have all the diagnoses for that patient and how sick that patient is? There are CMS multipliers, and so those multipliers are used to calculate the actual CMS payment. And then the factors into bidding. So all of the factors go into this model, into this table, and we calculate all of those RAF scores and reimbursement payments based on the clinical conditions, the member's social status, the member's age, are all factored into calculating the risk score. So what type of conditions will map to an HCC? So here you'll see that high-cost medical conditions, so cancers, heart diseases, sepsis. So most of these are coming in from hospital specialties, sometimes PCP. So all of these conditions, chronic diseases and conditions, will map to an HCC. So there's acute, there's chronic, there's status codes, manifestations. All of these services will map to an HCC code category when properly documented and diagnosed. The diagnoses that are excluded from mapping are those that will not predict the future costs. So we'll use an example, and I thought I had an example here. We'll use the example of arthritis, so rheumatoid arthritis versus osteoarthritis. So osteoarthritis is not in the HCC model. Rheumatoid arthritis will be in the HCC model, so there are certain conditions or diseases that will not roll into the HCC model. When we talk about the table and the model, again, it's the list of all the diagnoses codes that roll into an HCC code category. Not all of the codes that are listed in the ICD-10 book will map to an HCC code. Okay. And so here we're looking at some of the HCCs in common practice. So of course, we see a lot of diabetes. So here are your HCC code categories for diabetes and weights that go along with those diabetes. So you have diabetes with chronic complications and you have diabetes with no complications. For those members that are documented with no complication, we tend to go back to primary care physicians and sometimes specialists to ask for specificity or manifestations that could possibly move this from a 19 HCC into an 18 HCC by including the manifestations or chronic diseases associated with your diabetes. So nephropathy, peripheral, all of those diseases that are associated with diabetes will increase your RAS score if we can get the specified manifestations related to diabetes. Here we're showing protein calorie malnutrition and morbid obesity. Protein calorie, if you have patients that have cancer in their documentation or history, we want to document their protein calorie malnutrition if their BMI is lower than 19. So those conditions we want to at least review to make sure they meet the category or diagnosis status for protein calories. And of course, BMI, for those BMIs that are in excess of 39, we want to look at morbid obesity as your ICD-10 code that comes in through encounter. So all of the others, so these are just kind of the common conditions and diseases that we see through the encounter data. And you want to ensure that all of these diagnoses and diseases are documented at least once a year in the calendar year in order to stay in the patient's chart in the history. So if that amputation goes away in the year that you're reporting, CMS will not pay us on that condition, and they will assume that those limbs have come back, and we will not be able to record the amputation diagnosis. So every single year that you see that patient, you have to document those conditions again within the calendar year in order for it to store in the data. Preferably, your documentation of your disease and your ICD-10 should come in the beginning of the year, because those payment calendars and those CMS data files, they're going in through what we call a CMS sweep. And in order for us to have your data accepted by CMS, it's going to set our reimbursements and it's going to set your risk scores based on the CMS timeline and calendar. So we know that the CMS sweeps occur at the end of January, they occur in March, and they occur in September. So those are the sweep dates. And so our goal is to try and get all of our data in, for the March sweep, and we want to get our data in before the September sweep. And then for final years, we want to make sure all of our data is in for the January sweeps in order to ensure that CMS is capturing every diagnosis that you've defined as being chronic in your patient's chart. So just a list of some of the common HCC codes within practice and wage adjustment factors. Some of these factors will change. Keep in mind that this is based on patient's age, patient's social status. So these wage factors based for your individual patients may change depending on their status. Okay, and then here, the coding impact. So we want to remember that you must have a billable provider type designated in order to count your HCC. So a physician, a nurse practitioner, a PA. So we're counting risk adjustment based on your billable provider type. We want to have your encounter receive once within a calendar year, face-to-face encounters, and all of the data that gets included as part of risk adjustment would be your hospital services, of course. And we include outpatient services, office visit services, ER, et cetera. So those services will all be counted towards risk adjustment. The HCC should be supported by specific documentation and diagnoses. So as you're working on your health assessment tool, if you're working on your annual wellness exams, I know there are various plans that may have their own forms, but keep in mind you should either have your forms attached to your EHR or to your paper progress notes, and documentation should be present within your medical record somewhere. So even if it's an attachment or if you have written documentation, we will look for supported documentation for those specific diagnoses that are being reported to both the plans and to CMS. So here what we're looking at on the educational side is making sure that our physicians and offices understand coding guidelines and the coding language. So you hear the term care gaps, or we want to close the gaps. So we're closing those gaps related to the HCC chart that we saw above. What we're looking for is over a 3-year period, if we've identified that the member has a chronic disease or condition, that disease is likely not to go away. So we're looking at the chronic disease care gaps to say in 2018, the patient had a diagnosis. Did we recapture that diagnosis in 2020? When we're scheduling our annual wellness exams for 2021, do you have a clear list of who had the chronic diseases within your offices? And are you able to document those conditions because you have the right resources and you know which conditions were documented in a prior year? So we want to understand what those care gaps are within the practice so that you're reassessing and reevaluating that. We also need to understand the coding guidelines and the language. And we also want to understand when we're coding and documenting history of codes or current codes, we need to show those relationships. So history of codes, there are a few, but you're probably not going to get risk adjustment on your history code because in some cases it's going to show that those conditions are resolved. For the other codes that are in the model, we want to show the relationship between those diagnoses and conditions. So the words like with or due to or secondary to, associated with, that's the type of language that you want to use in your documentation. So here we see a lot of history of CAD with angina or history of CHF. So these are history codes that are probably going to fall off of your HCC documentation list, and we're probably not going to get risk adjustment because there probably will be some unspecified code or something that describes a condition that may have been resolved. So instead, we want to use, the patient has CAD with stable angina or nitroglycerin present. So this is just a better way or more efficient way to document those conditions or diseases within the chart so that we're capturing any associated diagnoses related to the relationship between two conditions. And so here we've seen these charts before. So we want to document, you're monitoring it, you're evaluating, you're assessing, and you're treating the condition. And with TAMPER, you'll see that there's a treatment and assessment. You're monitoring, you have a plan, and you're evaluating or you're referring to a patient. So keep in mind, if you are still surveying a patient's chronic disease or condition, so you're treating it by sending them to a specialty visit, you're still running labs on a particular condition, or there's medications being generated for a certain condition, that diagnosis has not been resolved. There is still ongoing surveillance related to that diagnosis, so it should continue in your patient chart or medical record until you show evidence that you've resolved it. So if you're submitting referrals, medications, labs, continue to document the chronic condition unless there's evidence that that disease has been resolved. Okay. So how do you apply it? So you want to diagnose all codes and conditions that are addressed. Level of service, so you need specific documentation. We talked about that. The assessment and plan should describe the status of the chronic condition. So you want to use words like stable, it's improving, worsening, controlled. So those are all descriptions that you should use in your progress note when documenting the medical record over to us. So here is just an example of what we would receive, an estimate of what you could potentially receive if we have proper documentation. So in this coding scenario, we have the same patient who is 76 years old. And we're going to look at conditions documented and appropriately coded. So this 76-year-old female, you can see we're documenting, well, she has demographics. So here's her age demographic, and these are kind of the totals that make up her demographics. Here you'll see we're documenting diabetes with chronic manifestations. We also documented the chronic congestive heart failure. We also documented the disease interaction between the diabetes and the congestive heart failure. So when we talk about that added value, so this is that added value because we conjoin the diabetes with congestive heart failure. That gives us an add-on value here because those two are associated together. And it makes up a risk score of 1.5 and just an estimated monthly payment of $13,000 because we properly documented all of the chronic diseases conditions. And keep in mind, these numbers are just estimated based on one particular scenario. So this may not be true for all members. It depends on demographics and other social factors. But the point we're making here is that with proper documentation, we're getting the add-on factor, and you can see that that RAF score value is 13,000 based on documentation here. In the next category, where we see chronic conditions that are not documented or not specified. So we have the same patient with all the demographic information listed here. We coded the diabetes and the chronic manifestation, but we did not associate her CHF. Since we did not associate CHF, we lose the CHF weight. We also lose the add-on factor connecting the diabetes to the CHF, and therefore we get a lower RAF score and we get a lower payment. So this is almost split into half because we did not include the CHF diagnoses with our diabetes as a relationship. So this is almost half. And so when we look at our RAF scores, we can say, well, in the first year, I'm getting paid pretty well on this member. And the next year, what happened? My RAF score cut in half. And that's because we should look to see if we have documented all of the conditions or disease that were originally captured in the prior year's chart. So here's an example of that. And then the next patient, so let's say if we have the same patient, same demographic, and we receive no data at all. So here we capture this in a prior year. So here are all our conditions in the prior year, but now we're in a new year. And so there's no diabetes captured for the patient. We didn't get our CHF. We didn't get the interaction. So this is a standard base rate based on patient demographic. So it's much less than what we would have received if we would have documented all of the conditions. So year over year, continue to document, continue to associate conditions. And I think we tend to leave off this disease interaction when we're not connecting the two conditions and diagnoses together. And in the above slides, those are samples of how those relationships and documentation should be made in the chart.
Sorry, quick question.
And here, yeah.
I'm sorry, what's the difference between the two diabetes codes in the two scenarios?
So
the diabetes with chronic manifestations?
So this is diabetes with chronic manifestations. This is also diabetes with chronic manifestations. So in your diabetes, if you look at the HCC or the diagnoses for diabetes, we have categories 17, 18, and 19. And within those diabetes codes, you have manifestations or conditions associated in both HCC code categories. So this could be, a range of different codes in 18 and a range of different codes in HCC code 19. So we can absolutely share with you the HCC code model so that you can see the differences, but not all codes for diabetes roll up into 18 and not all codes roll up into 19. So here is probably a variance between the E code that's being used in category 18 versus category 19.
Got it. Thank you.
Yeah. Yeah, and we can share that chart, and I think that'll be helpful for most on that call, is to receive the HCC code model that outlines all of the ICD-10s which map to an HCC category. So we can absolutely share that chart with you. Okay. And concluding, here we just have reminders of making sure that our records are legible, and most of you now are probably on an EHR. So if you're using EHR, there are certain EHR systems that will identify when your code risk adjusts and when your code does not risk adjust. So for those EHR systems that are not using some sort of add-on module to identify risk adjustable codes, we want to make sure that you have some sort of trigger, or if you're using one of your health plan health assessment forms, a way to identify what those prior year conditions were before scheduling your patients or seeing your patients. So it's always helpful to run eligibility, and your second habit should be, do I have a list of all the chronic diseases I should assess before the patient comes in? Sometimes we have patients that come in because they're, maybe it's just a runny nose, or they're not feeling well. That may be our one opportunity to capture our chronic disease and conditions. So wherever possible, we always want to have our doctors equipped and aware that these are the chronic conditions that we should be reassessing during that visit. Specificity, we talked about coding to the highest degree of specificity. So where we can stay away from unspecified codes, let's make sure that if it's a code available and your condition is chronic and you have a manifestation, that we're coding and documenting those manifestations. Discrepancies that we find between diagnosis code versus what's billed. So if you have a doctor who is charting in a progress note, we want to carry that forward in our billing. So we want to make sure that our billers are using the proper coding criteria when submitting the diagnoses. And also, if you're submitting a list of diagnoses that exceed the amount allowed on your EDI submission or your paper submission, that you're sending a subsequent claim to capture all of your diseases. So there are times where we'll see that maybe we didn't get your cancer diagnosis because it was diagnosis code number 14, but we got all of your runny nose and all your other conditions. So if you find that you do not have enough space in your submission for your EDI record or for your paper claim, you may need to submit a subsequent claim to ensure that we're receiving all of your diagnoses. We talked about the NEAT, documentation, monitoring, evaluating, and assessing, making sure that all your chronic diseases are documented and that we are getting that specificity. Statuses of cancer, so if we have the treatments, making sure that you're documenting treatment statuses of certain cancers. So that's important. There is a method that we use with algorithms to data mine on those members who have received certain medications where we do not find a chronic disease or condition, or members that have lab values that we suspect there should possibly be a chronic disease or condition. So all of these algorithms that we generate related to medications and related to lab, we think based on those identifications of medications that we're probably missing a diagnosis that should appear in the chart. So when we're sending out hats or if we're sending out additional reports related to medication, it's because the members are filling prescriptions and we believe that there's a suspected condition related to those diagnoses. So just properly documenting and also looking at your lab and medication records to ensure we're capturing those conditions. And then lastly, making sure that we're linking those conditions. So we saw in that example of the 76-year-old patient that when we link conditions together, we get the added value on the RAF score, and that will increase our payment for the calendar year. So with that, that concludes our discussion today related to ICD-10 changes and risk adjustment changes. And I believe that Liz is going to record any questions that we have to specific conditions. We'll take those offline, but if there's any general questions, I'd be glad to open up the session now for questions.
I have a quick question. In your example, how did you calculate the dollar value tied to RAF?
Yeah, so the way that this was calculated is we took the patient demographic information. So that information comes in from CMS. So we have patient age, we have patient health status. In the CMS announcement, and it can get very complicated, but in the CMS announcement, they give you a weight value for each member's wage factor. And there's a calculation where you can enter a member's age, you can enter a member's status, you can enter all the diagnosis codes, and it gives you a calculation. So there is a CMS table that provides you, data fields where you can key in some of this information to get an estimate on what the payment would possibly be for each individual member.
Oh, how do we access that?
So that information is available on cms.hhs.gov. In the search box, if you enter, if you enter in the search box HCC categories or HCC model, I probably would do HCC model. You'll get an entire page of CMS risk adjustment model tables. There's a calculation table that you could use to estimate. And if you're not able to find it, just leave your information in the chat box and we'll be sure to send you a link which directs you to that location.
Perfect, thank you. And I'm sorry, one more question. How do you link the congestive heart failure with diabetes? Is that just in the documentation?
Yeah. It's a diagnosis code. So it's in the documentation on the diagnosis code. So Liz, if we can document that question, we can send the diagnosis codes that we use, and I believe it's on one of the slides here. We can send the diagnosis codes that we use to link the diabetes to the CHF so that you're getting both codes together under the proper ICD-10. So we'll take that back and we'll send out the direction of how that's coded.
Thank you.
Okay, thank you.
I have a quick question. You did a great presentation, and some of the people I work with weren't available today to watch. Is this recorded anywhere that I could have other members of my team see this, because it was so good?
Oh, well, thank you very much. Liz, can I confirm, are we posting the recordings on our website, or are we just distributing the documentation?
Actually, we started, they're getting converted to YouTube.
Okay.
Last one was already converted. And this one, I believe, will also be converted. And eventually we're working with the programmers to upload them to the website, but it is available as soon as we get the link from our marketing team, so we can forward
Okay. Okay, good. Okay, so forward it to SMA, Senior Medical Associates. All right, thank you. That was really very good. I appreciate it very much.
Good, thank you for participating.
Michelle, did you want me to go through a few of the questions, or just take them all back on the F for you to respond offline?
Yeah, so what we'll do with the specific coding questions is we have an FAQ, and we will complete the frequently asked question document. I know a lot of the questions are related to specific coding examples, and we want to give you accurate information based on documentation. So we'll take that back through the FAQ, and everyone who's registered to this call will make sure that you receive those FAQs within the next several days, and we'll have documentation and answers to all of your questions there. Okay. So with that, I'd like to thank everyone for participating. Just a reminder that these trainings occur the third Thursday of each month. Our provider service team, they will receive questions. If you have questions regarding coding, or if you need specific trainings, reach out to our provider services team, and we'll be sure to get you either on the schedule, or we can provide you with learning materials to help with documentation and coding.